This is a Dutch testing report tutorial. Please do know that these educational videos are from information only and not to be considered any sort of medical advice. The results that we're going to show here are generic results and don't indicate your actual results or any patient's actual results, but just meant to aid in the conversation. There's a lot of data here that we can look at for cortisol, but the main thing that we want to look at, or things that we want to look at, are the free cortisol pattern. So we're measuring free cortisol at 4 different time points. The waking sample is going to tell you what the free cortisol looks like while you're sleeping. The morning sample gives you the cortisol surge in the early morning, if there should be one. And then in the afternoon, results typically drop back down, and then we have a bedtime measurement as well. So we want to look at the 4 measurements on yours, which overall are a little bit on the low side, but looking for this diurnal pattern and dysfunction in the pattern itself. Then we're going to add those 4 up to give us an indication of the free cortisol overall. And that number, again, in this particular situation, is below range, which shows you there's not a lot of free cortisol. So that's an important measurement, but it's not really the best measurement for overall glandular output of cortisol. What we call metabolized cortisol really is the best marker for the total cortisol production. So we want to look at that as well. And this is a situation where we've got a little bit of, or a lot really, of a discrepancy in that the free cortisol is relatively low and the metabolites are relatively high. So we've got to think our way through that a little bit in terms of what that means. As we back up a little bit and just discuss what happens when cortisol is made, the adrenal gland gets a signal from the brain by way of ACTH. That's a signaling hormone from the brain to the adrenals saying, time to make cortisol. So it makes cortisol, and as it circulates, it goes back and forth between cortisol in its active form and what's called cortisone, which is the inactive form. There's an enzyme called 11-beta HSD that interconverts it back and forth, and you can see a depiction of that on the bottom part of that page 5 that has more detailed information about the cortisol. So it's going back and forth. So because it's going back and forth, we also want to look at the free cortisone pattern. Now, it's not of primary importance. Of primary is cortisol, but the cortisone helps to sort of confirm what's going on. So if the free cortisol pattern is low, as is the case here, then we want to look at the cortisone, and if it's also low, then it confirms that there's just not a lot of free hormone. If it's a little bit higher yet, then maybe there's a little bit more free cortisol that's systemically circulating. The other question that we can ask is whether there's overall a big preference for deactivating cortisol to cortisone. We'll get to that in a minute. But we've got the free hormone that's circulating in any of these 2 forms, and then it is metabolized. And so when we look at metabolized cortisol, which is again our marker for total production, it's the combination not of cortisol and cortisone, but of their metabolites. So those downstream metabolites, when this metabolism happens, it is irreversible. So now they're ready for excretion, and they're excreted in pretty high concentrations as these metabolites, especially in this case. So what that implies in a case like this is that there is increased cortisol clearance, right? If the free cortisol is relatively low and the metabolites are relatively high, then there must be, or it would imply that there's a lot of cortisol clearance going on, which is upregulated by obesity, high thyroid, potentially long-term exposure to cortisol or cortisol-like medications. So if you have opposite situations in other patients where the free cortisol is relatively high, even though the production being low, which is a picture of slow cortisol clearance, you'll see that oftentimes in low thyroid cases, poor liver function. So we want to piece the whole thing together, looking at the free cortisol pattern over time and then the total production. The other thing we can see, as we said, is there a major preference for this particular patient to deactivate the cortisol and leave it in cortisone form, or is there a preference the other way? And the way that we look at that is not as much to look at the free pattern, because the free cortisol is about 1%. where most of it ends up is in these metabolites. So we can also look at the question, which metabolites do we have more of? Cortisol or cortisone? Which is predominating, the active form of cortisol or the inactive form of cortisone? And that helps to shape this overall picture. So again, free cortisol over time, total production, and then any metabolic preference that we might have. We want to look at all of those things as we piece together what's going on with this patient, and of course, overlaying the clinical picture and the symptoms that we might have. In a case like this, where the free cortisol is relatively low and the production is high, it may be a situation where it depends on where you are in the body as to what the cortisol status is. Certainly, if the cortisol production is high, and the first place the cortisol goes is into the middle of the adrenal gland. In the middle of the adrenal gland, cortisol pushes noradrenaline to adrenaline. So it can increase adrenaline or epinephrine production. That's something to think about, because in a case like this, the implication would be in that environment, there's probably quite a lot of cortisol because a lot of cortisol is being produced, and that's the first place it goes. However, in the brain, it's most likely that the free cortisol represents that environment, the circulating cortisol, which may be relatively deficient. So these types of situations are quite complex, where we have these different sorts of pictures of cortisol depending on where we're looking, and we need to carefully go through that one piece at a time, and again, overlaying the clinical picture as we decide what's best for a particular patient when they've got these more complex cases. And that's why we want to present more data with this test as it relates to cortisol, because it can help us piece together better a clearer picture of what's going on with this patient. So I hope that's been helpful. We do have more information at dutchtest.com, and if you're watching this from a patient perspective, please do point those questions that you have about your particular case back to your healthcare provider, and we thank you for testing with us.